Welcome back to the deep dive.
Oh,
We're doing something a little different today.
yeah, definitely a change of pace.
Usually we take a broad topic and sort of explore the edges, but today feels a bit more like a tactical briefing. We are essentially doing a don't kill the patient cram session for all of you out there.
That is a very high stakes way to put it. But honestly, looking at the source material we have today, it's accurate. We are diving into musculoskeletal emergencies.
Right. And the trap with this topic, especially if you're a nursing student prepping for the NCLEX, is assuming it's just, memorizing bones or knowing how to wrap a bandage.
Yeah, it's so much more than that.
It really is. The literature here paints a much more intense picture. This isn't about a broken pinky finger. It's about systemic shock, crushed nerves,
Yeah.
and fat emboli hitting the lungs.
Exactly. When you look at the clinical judgment required here, it usually boils down to two massive red flags. You are constantly asking yourself as the nurse, is this an immediate threat to the limb, or is this an immediate threat to the life?
And we're going to structure this deep dive right around those two pillars, limb threat versus life threat. Plus, we'll do a rapid-fire round on the mechanics of the equipment, like casts and traction.
Because the safety rules there are incredibly specific.
Right. And if you get the mechanics wrong, you can actually cause the exact emergency we're trying to prevent.
Absolutely. You can cause irreversible damage.
So let's start with the limb threat. The sources are pretty much unanimous here. The big bad wolf of orthopedics is compartment syndrome.
It is the #1 priority assessment for any fracture or crush injury, bar none.
I want to get specific on the pathophysiology first, because I think if you understand the actual mechanics of the injury, the symptoms make way more sense. We aren't just memorizing a list here.
Right. Context is everything.
What is physically happening inside the arm or leg to cause this?
So think about the anatomy. Your muscles aren't just free floating in your leg. They are grouped into compartments, and those compartments are wrapped in fascia. Now, fascia is this really tough, fibrous connective tissue. It's great for structural support, keeping everything tightly in place.
But it has a major design flaw in an emergency.
Right. It does not stretch
Wow.
at all. It's like a tight leather casing around the muscle.
Yeah.
So if you have a crush injury or a severe fracture, you get bleeding and edema swelling inside that tight leather casing.
And the pressure just starts to rise.
Exactly. Normal compartment pressure is almost nothing, maybe 0 to 8 millimeters of mercury. But in compartment syndrome, it shoots up past 30.
Wow. And since the casing won't expand, everything inside just gets squashed.
Specifically the microvasculature. The capillaries get crushed first. So blood can still pump into the leg through the big arteries because they are under high pressure, but the blood can't get out through the veins.
Right.
And it certainly can't get into the tiny capillaries to actually feed the muscle tissue.
So the tissue effectively suffocates.
Yeah, it creates this vicious ischemic cycle. The muscle dies from lack of oxygen, it releases toxins, it swells even more, and eventually the nerves die too. And once that tissue is necrotic, it's gone.
You're looking at amputation.
Amputation or permanent severe disability, like a Volkmann's contracture.
Okay, so as the nurse, your job is to catch this before the necrosis sets in. The sources all point to the 6 Ps as the memory hook for this. But I want to parse these out because some are early signs and some are, well, you're already too late signs.
Correct. And that distinction is exactly what the NCLEX tests. You have to know the timeline. The first, and really the most critical sign, is pain.
But here is the pushback I always hear on that, and frankly, it's a valid question. The patient has a broken femur. Of course they're in pain. How do you distinguish compartment pain from standard fracture pain?
This is the nuance. The literature describes it as pain out of proportion to the injury.
Out of proportion.
Right. So picture this scenario. You've given them the ordered opioids. You've repositioned them comfortably. It's been 30 minutes, and they are still screaming in agony.
The drugs just aren't touching it.
Exactly. That is your first red flag. And there is a specific physical assessment technique mentioned in the sources for this. Pain on passive stretch.
Oh, right. This is the gold standard assessment, isn't it?
It is. Let's say it's a lower leg injury. You, the nurse, gently pull the patient's toes back toward their nose. You are passively stretching that calf muscle.
And if it hurts.
If that movement causes excruciating pain, that is compartment syndrome until proven otherwise.
Because you are manually stretching a muscle that is already strangulated by all that pressure.
Exactly. It's highly specific to this condition.
Okay, so pain is number 1. Then we have paresthesia.
The pins and needles. Numbness, tingling. This is also an early sign because nerves are very, very sensitive to pressure and ischemia. If the patient says their foot feels like it's asleep, you listen to them.
Don't brush it off.
Never.
Then we move down the list. Pallor, the limb goes pale. Paralysis, they can't move their toes at all. Poikilothermia, which is just a fancy way of saying the limb is cool to the touch compared to the other leg.
Right. It takes on the temperature of the room. And finally, the last P is pulselessness.
And this is the trap, isn't it?
It is the biggest trap in orthopedic nursing. Students often think, oh, I'll just check the pedal pulse. If I feel a pulse, everything is fine.
Right, because we're taught pulses equal perfusion.
But here, it's wrong. Pulselessness is a late and very ominous sign. By the time the pressure is high enough to collapse a major artery, the muscles and nerves have already been dead for hours.
So if you wait for the pulse to vanish, you have essentially failed the patient.
Precisely. You need to be catching this at the pain and paresthesia stage.
Okay, scenario time. I am on the floor. I suspect compartment syndrome based on the pain and the tingling. What is my actual order of operations? Because the sources list a specific do and a very controversial don't.
The do is immediate notification. You assess the neurovascular status bilaterally, always compare the bad leg to the good leg, and then you call the provider.
Right.
This is a surgical emergency. The fix is a fasciotomy, where they literally slice open the fascia to relieve the pressure.
But while I'm waiting for the surgeon, the don't.
Do not elevate the limb.
Which goes against literally everything we
Yes.
learned about swelling. Rice rest, ice, compression, elevation.
Yeah.
We are taught from day one to elevate sprained ankles to bring swelling down. Why is this different?
It comes back to physics and perfusion pressure. In compartment syndrome, the pressure inside the leg is already fighting the arterial pressure that's trying to push fresh blood in.
Okay.
If you elevate that leg above the heart, you are making the heart work against gravity on top of everything else. You essentially lower the arterial pressure at the site of the injury.
So you might be helping the swelling drain slightly, but you are actively killing the blood supply.
Exactly. You are accelerating the ischemia. You want that limb flat right at heart level to maximize arterial flow into the compartment.
And I assume compression, the C in RICE, is also out.
Completely out. No tight ace wraps. Nothing. In fact, if they have a cast on, the provider might order it to be bivalved cut in half immediately, just to release that external constriction.
Got it. So pain on passive stretch. Notify the provider, keep the limb flat. That is the limb threat. Now, let's pivot to the life threat.
Fat embolism syndrome, FES.
This one honestly scares me because it feels so silent. It's insidious.
It really is, and it catches people off guard because of the timing. With a regular blood clot or pulmonary embolism, a PE, we worry about that pretty much any time a patient is immobile for a while.
Right.
But FES is specific to the injury type. We are talking about long bone fractures, femurs, humerus, or pelvic fractures.
Because the yellow marrow inside those adult bones is full of fat.
Right. When the bone snaps, those fat globules break loose. They enter the venous circulation and travel straight to the lungs.
Just like a blood clot would.
Yes, but it's not just a mechanical blockage like a blood clot. The fat globules actually break down into free fatty acids, which are highly toxic to the lung tissue. It triggers a massive inflammatory response.
So the lungs get inflamed and filled with fluid. And the timing you mentioned is key. This usually happens 24 to 72 hours after the break.
Yes. It's rarely immediate. It's usually day 2 or day 3 that they crash.
The sources describe a classic triad of symptoms. If we see these three things together, we need to act immediately. Break them down for us.
Number 1 is respiratory distress. Hypoxia, shortness of breath, rapid breathing. That's the fat physically clogging and inflaming the lungs.
Makes sense. Number 2.
Cerebral dysfunction, confusion, restlessness, altered mental status. And this is often the very first sign you'll notice.
Wait, really? Why is that?
Because the brain is the most sensitive organ to low oxygen. Before the patient even complains of trouble breathing, they might just start acting weird. They get agitated. They try to pull their IVs out. They don't know where they are.
So if my femur fracture patient suddenly thinks I'm their grandmother, I don't just assume it's the morphine making them loopy.
Never assume it's the meds or ICU psychosis until you completely rule out oxygenation issues. Check their O2 saturation immediately.
And the third sign. This is the one that really distinguishes it from a regular blood clot.
The petechial rash. This is a red pinpoint rash that appears on the chest, the axilla, the armpit, and sometimes the neck or even the conjunctiva of the eyes.
Why does it happen there?
It's thought to be related to the thrombocytopenia, the low platelets, that often accompanies the fat embolism. but clinically, it's your hallmark sign.
So it's a massive differentiator.
Huge. If you have a patient with a broken leg who gets short of breath, it could be a PE or a fat embolus. If they pop that red pinpoint rash on their chest, it's almost certainly a fat embolism.
That is a crucial test distinction for the NCLEX. PE equals chest pain and breathing issues.
Yeah.
FES equals breathing issues, confusion, and the rash.
Spot on.
So treating it, is there a clot buster for fat? I mean, we have TPA for blood clots.
No, that's the hard truth here. You cannot dissolve the fat. The treatment is purely supportive.
So what do we do?
You oxygenate them, high flow O2, or intubation if it's really bad. You support their circulation with IV fluids, and you essentially wait for the body to clear the lipids on its own.
Which means prevention is really the only cure here.
Immobilize the fracture. That is the absolute nursing priority. The less that broken bone moves, the less fat leaks out into the blood. That's exactly why surgeons rush to fix femurs so quickly.
Okay, that covers the physiology of the main disasters. Let's move to segment 3, the mechanics of care. We're talking about the hardware. The sources have a lot of do's and don'ts regarding casts, hips, and traction.
This is the stuff that seems basic, maybe even a little boring, but it causes a lot of complications if you get lazy with it.
Let's start with hip replacements. Specifically, the posterior approach, which seems to be the most common one tested. The new joint is highly unstable. We have these forbidden movements.
Correct. When they cut through the posterior muscles to put the new hip in, they severely weaken the support structure back there. If the patient moves the wrong way, the head of the femur just pops right out of the socket.
Complete dislocation.
Yes, and it's agonizing.
What are the 3 rules to prevent that?
Rule 1. No flexion past 90 degrees.
So this means the angle between the torso and the thigh.
Right, so they cannot bend over to tie their shoes, they cannot pull their pants up from the floor, and the big one for nursing, they must use a raised toilet seat.
Because on a standard low toilet, your knees end up higher than your hips, which breaks that 90-degree plane.
And pop goes the hip.
Rule 2.
No adduction. Adduction is adding to the midline, so no crossing the legs, not at the knees, not at the ankles.
I've seen those wedge pillows they use in the hospitals, the abduction pillows.
Those are essential, especially when the patient is sleeping and might unconsciously roll over and cross their legs. The pillow physically forces the legs apart.
And rule 3.
No internal rotation, no pigeon toes. You want the toes pointing straight up or slightly outwards.
Okay, that's hips. Let's talk casts. Specifically, plaster casts while they are actively drying. The source material had a very weirdly specific rule about palms versus fingertips.
It's a classic orthopedic rule. When plaster is wet, it's highly malleable. If you handle the heavy leg with your fingertips, you press deep indentations into the cast.
Like poking wet clay.
Exactly. But when that cast dries over the next day or two, those indentations turn into hard, permanent bumps on the inside of the cast, and those bumps press directly against the patient's skin,
Creating pressure ulcers.
which you can't even see because they are hidden under the cast. So you always handle a wet cast with the flat palms of your hands to keep the pressure distributed evenly.
And speaking of things under the cast, the itch. It is inevitable. The patient's going to want to scratch.
Oh, and they will try to use anything. A coat hanger, a pencil, a knitting needle, a ruler. You have to be militant about this. Nothing goes inside the cast.
Why is it such a massive deal? Just a little scratch.
Because the skin under a cast is often very fragile and slightly moist from sweat. If they scratch it with a dirty pencil, they break the skin.
Oh, I see.
Now you have an open wound in a dark, warm, moist environment. It is a perfect petri dish for bacteria. We see horrible, limb-threatening infections just from someone scratching with a hanger.
So what do we tell them? Just suffer in silence.
No, we tell them to use a hairdryer on the cool setting. Blow cool air down into the cast. Or you can have them tap on the outside of the cast to distract the nerves. But never, ever insert anything.
Good tip. Finally, traction. This is where I think people really get confused between skin traction and skeletal traction.
The principles are similar, but the invasiveness is totally different. Skin traction, like Buck's traction, is a boot or a Velcro strap applied to the outside of the skin. It's usually temporary, pre-surgery, just to stop muscle spasms.
And skeletal traction is the heavy-duty stuff.
Right. Pins or wires actually drilled directly through the bone.
For both of these, there is a golden rule about the weights at the end of the bed.
The weights must hang freely. Always. Gravity is the engine here. If the weights are resting on the floor or sitting on the bed frame, there is zero traction being applied. The muscle will immediately spasm.
So if I walk into the room and the weights are sitting on the floor,
Yeah.
I don't just pick them up with my hands. I need to physically move the patient up in the bed so the weights hang free again.
Correct. And specifically for skeletal traction, where those pins enter the skin, we need to talk about pin care.
Because that is a direct highway for bacteria right into the bone marrow.
Yes. Osteomyelitis, a deep bone infection, is the huge risk there. You need to clean those pin sites, usually once a shift, typically with chlorhexidine or whatever the facility protocol is. And you're always looking for tenting of the skin or any purulent drainage.
And you never remove the traction weights unless it's a life-threatening emergency or you have a specific direct order, right?
Never remove them. If you release the traction on a fresh femur fracture, those massive thigh muscles will contract violently. The jagged bone ends can shear right through nerves or major blood vessels. It is agonizing for the patient and incredibly dangerous.
Okay, we are heading into the home stretch here. I want to do a clinical judgment blitz. I'm going to throw a symptom or a drug at you, and you give me the absolute must-know fact or the immediate intervention.
Let's do it. I'm ready.
Topic.
Yeah.
Back pain.
Yeah.
But the patient has just lost control of their bladder.
Cauda equina syndrome. That is a massive medical emergency. The nerves at the very base of the spine are severely compressed. If you don't decompress that surgically within hours, the incontinence and paralysis can be permanent.
Topic. Crush injury. The patient was pinned under a car. Their urine is dark brown.
Rhabdomyolysis. The crushed muscle is breaking down and releasing myoglobin into the blood. That brown urine is actually myoglobin clogging up the kidneys. You need to flood them with IV fluids to flush the kidneys, or they will go into acute renal failure. Watch their creatine kinase levels. The CK levels will be sky high.
Topic. Pharmacology. Bisphosphonates, like alendronate for osteoporosis.
This is the sit-up drug. You have to take it in the morning on a completely empty stomach with a full glass of water, and you must sit perfectly upright for at least 30 minutes.
Why the upright rule?
Esophagitis. If they lie back down, the pill can reflux and literally burn a hole in the esophagus. It is extremely corrosive to that tissue.
Wow. Okay, topic. Gout. We are prescribing allopurinol.
Allopurinol prevents uric acid production, but the key in nursing teaching is hydration. The patient needs to drink up to 3 liters of water a day to prevent kidney stones from forming as that uric acid clears out of their system.
And finally, phantom limb pain. The patient had an amputation last week. They are crying and they say their meeting foot hurts.
It is real pain. Do not dismiss it as psychological. The nerve endings are severed, but they are still firing signals to the brain. You treat it with pain meds, often gabapentin or certain antidepressants for nerve pain, just like you treat any other physical pain.
Function over skepticism.
Always. Believe the patient.
Okay, that was a marathon. Let's wrap this up with a rapid-fire recap for everyone listening. I'll give the cue, you give the action.
Ready?
Pain on passive stretch.
Compartment syndrome. Notify the provider. Do not elevate above the heart.
Confusion and a pinpoint rash
Yeah.
on the chest.
Fat embolism. Oxygenate immediately and stabilize.
Wet plaster cast.
Palms only. Absolutely no fingertips.
Posterior hip replacement.
Abduction pillow. No crossing legs. No 90-degree flexion.
Weights on the floor.
Move the patient up in bed. Weights must always hang freely.
We have covered a massive amount of ground today, and I think what stands out to be the most, looking at all of this, is that musculoskeletal nursing isn't just about bones at all. It's about circulation, it's respiration, and it's neurology.
That's the ultimate takeaway. You know, we spend so much time in nursing school memorizing lists, the 6 Ps, the triads, and that is necessary scaffolding. You have to know it. But the real skill, the one that actually separates a novice from an expert nurse, is trend recognition.
What do you mean by that?
Rarely does a patient go from completely fine to coding in 1 second. There's almost always a drift. Clinical intuition is noticing that the patient required 2 milligrams of morphine an hour ago, but now they need 4 milligrams and they're still crying. It's noticing that their O2 shot was 99%, then it was 95, and now it's 92.
It's the slope of the line.
Exactly. If you just look at the snapshot, you might miss it entirely. But if you look at the movie, the trend over time, you catch the compartment syndrome before the pulse is ever lost. You catch the fat embolism before they stop breathing.
That is a really powerful place to end. Don't just watch the patient. Watch the trend.
That's how you save the limb and the life.
Thank you for guiding us through this. Listeners, you have your cram sheet. You know the red flags. Go crush that exam.
You've got this.
We'll see you on the next deep dive.